We got a lot to cover ahead of us tonight. Very excited about this panel. We've been kind of waiting for it for a long time, and hopefully one of many more to come. I'm Dr. Stephen Dahmer. I'm the Chief Medical Officer of Goodness Growth Holdings, Vireo Health, joined by Dr. Julia Arnsten and Olivia Uhley. We'll be talking about cannabis and chronic pain and some of the clinical research that's going on right now. This is a disclaimer that we share before all of our lectures. Still, designated cannabis alongside heroin as a Schedule I substance under the CSA of 1970, the most restrictive category, substances with a high potential for dependency and currently no accepted medical use, something certainly many of us are working against, and I look forward to the day where I don't have to share this disclaimer. A few slides to lead up to the preliminary data from the MEMO trial and a little bit of a discussion about the ReLeaf trial. Many of us are aware, and I've been watching this map grow steadily over the last 7 years, that medical cannabis now legal in 37 states. And estimates, this was accessed data from March of last year, but MPP is estimating nearly 5.5 million Americans that are utilizing medical cannabis with a doctor's recommendation. And for those patients that aren't in a state legal program, anyone that is a practicing clinician, there is estimates that 1 out of 10 of the adults in our waiting room over age 26 has used cannabis in the past month. These numbers continue to grow, and as you see, these aren't up to date. We don't have current statistics on this, but obviously prevalence of cannabis use is certainly growing as well. And one of the few things Americans agree upon, 91% agree with the statement that medical cannabis should be legal. And we certainly see that pressure and the growth of the program surrounding us on all sides. I would say, from a medical perspective, I truly believed in 2017 with the results of with the report released by the National Academy of Sciences, Engineering, and Medicine, we started to see a tide turn even more towards the exploration of cannabis as a potentially legitimate treatment for chronic pain. This over 10,000 abstracts were looked at by the Academy and came away with many recommendations and many insights, including in adults with chronic pain, patients who are treated with cannabis or cannabinoids are more likely to experience a clinically significant reduction in pain symptoms. Early in the days of Vireo Health, one of the first things that we knew we wanted to do was support research. It really made a lot of sense, as we saw from the early days and subsequent polls and even data supplied from there. The vast majority of our patients qualify, the qualifying condition is chronic pain. In conjunction with some of the best evidence supporting chronic pain, it seemed a logical area to explore further for research. And again, preaching to the choir here, again, opioids, the main culprit here, and we all realize we're in the midst of this epidemic. It was an opportune time to further explore cannabis as an alternative, right, as an option for those looking to treat chronic pain. The impact of COVID-19 really only worsened that overdose epidemic, and also triggered, as I hope Dr. Arnstein is able to join here in a second, tremendous research challenges. Very hard to conduct research in the midst of the COVID-19, but also an increase in cannabis consumption. I think making this research even more opportune and timely, as we're seeing an increase in consumption, and even specifically in New York State, adult use on the horizon. And this is something that I think everyone on the call here is aware of. We want alternatives. This was an in-crowd study back in 2017. We long have been looking for an alternative to opioids, and the majority of that is behavioral health interventions, certainly vitamin herbal supplements, and a small percentage of that medical cannabis. And since the early days, as we followed the literature just over and over, this is what every study concluded at the end. Despite the evidence of this analgesic benefit, a scarcity of research on short and long-term effects, especially in chronic pain. basic science reviewing the endocannabinoid system and a rationale for clinical research, explosion of anecdotal evidence, but again, a call for more extensive cannabinoid pain research. Over and over again, undertaking quality research is almost impossible, and more hints at the challenge, specifically in a naturalistic setting. These nearly 5.5 million Americans utilizing medical cannabis in state legal programs, research, understanding better that use and better informing those. This is a recent virtual survey that I just found very informative. And I'll be very frank, as a physician in the space for 7 years, one of my biggest concerns in things moving forward, and in these groups, in terms of interviewing participants in the Pennsylvania program, there's just a true failure that I'm sure many of us have seen to integrate cannabis into the healthcare system. There's no overarching education about the medical use of cannabis. I would maybe argue with no, but little and not sufficient. There's little consistency and availability for people once they found a suitable product. Questions on symptom relief and high out-of-pocket costs, and a true lack of integrative care, which requires a patient to experiment themselves. And our mantra is start low, go slow, stay low. But I think what we've been yearning for a long time is better information to guide. And if you look at the literature, and certainly those that have participated in research see the tremendous challenges to cannabis research. And I do want to draw a distinction between, FDA approved synthetic cannabinoids that have been, available with prescription since 1985, and those supplied by state legal programs. And there is this quandary, right? This debate of an entourage effect. Do these plants of 1,001 constituents, slightly high estimate, but there is an article written to that, do they convey a different approach or treatment, or potentially benefit to those patients utilizing it? And in the history of the FDA, only 2 botanical drugs have passed through that process. On top of the complexity of the plant and in the products that patients receive in state legal programs, there's a tremendous range of products, doses, routes of administration. Placebo design with psychoactivity, specifically related to THC, some might argue to CBD as well, makes research very difficult. The majority of research, specifically in the United States, has been criticized for poor study design, small and short duration, and the vast majority of research related to harm, and the funding utilizing bud and flower with high THC and minimal, if any CBD. And probably the greatest barrier is its designation, as we hit on slide 1, as a Schedule I substance. And I don't think Dr. Arnstein's been able to join us yet. Correct me if I'm wrong.
Steve, well, she's logged in, but unfortunately is logged in as an attendee. So
Okay.
if we could have Olivia go next, and we're working out a fix for Dr. Julia as we speak.
Fantastic. We are going to skip ahead here. Apologize for the skipping, and jump to Olivia's section. And we'll come back to this here in a minute.
Hi, everyone. Thank you so much for attending this evening and also for your patience. I am Olivia Uhley. I'm one of the clinical research coordinators on the ReLeaf study. We can go ahead and push ahead to the next slide. So I will go through this material pretty quickly, but we're basically going to focus on specifics regarding the ReLeaf study itself. We will have time at the end, ideally, for questions regarding the study and research in general. But of course, feel free to pop those in the chat box if that feels right to you. So the study design of the ReLeaf study is incredibly innovative. It is unique in that it's comprised of 2 parallel studies, ReLeaf E, which is being coordinated by the Albert Einstein College of Medicine research team, and ReLeaf V, the side of the study being coordinated by the Vireo Health research team. So me and Jasenia Lopez are the clinical research coordinators working on the Vireo side. There are 4 arms to this study. It is blinded. It is a randomized controlled trial. So all participants will be assigned at random to one of 4 arms. So that, as you see below, there are 3 different possible Vireo Health soft gel oral capsule products. So these are all oral medications in pill form. as some of you may be familiar with them. We've got our green, which is the 1-to-1, our yellow, which is the higher THC to lower CBD 6-to-1, and the blue, which is the low THC to higher CBD and a placebo. As we explained to our participants, this means that it has no active ingredients from medical cannabis in the product itself. We have very strict titration guidelines that are based on validated outcome measures that we use. We use the same kind of idea that we use in clinical practice when it comes to medical cannabis dosing. We start low and go slow. So all of our participants started at a very, very low dose, and based on these validated measures, we work our way up gradually based on the patient's experience. So our key outcome for the ReLeaf study is opioid analgesic use. All of our participants self-report using prescribed opioid analgesic medications upon screening. We also do check New York State prescription monitoring program records to make sure that prescription opioid medications have been dispensed within the last 45 days for all of our participants. Our key associated outcomes include pain, substance use, mental health, and adverse events associated with the use of medical cannabis products. So the participant experience, if you were to send a participant to our study, this is what their experience would look like. It is a 14-week trial. All of our participants are asked to participate in 5 research visits. We've been able to make those more accessible, especially in the context of COVID-19, by doing the bulk of them remotely throughout the duration of this study. We do compensate our participants on the Arnstein side. They get compensated per research visit and per web-based survey they fill out weekly. And they can get up to $270 for their complete participation. On the Vireo side, they are given discounted vouchers. That is what they're randomized to. All of our participants are randomized to a product or to a voucher associated with a product, which is part of this unique study design. These vouchers allow our participants to purchase as many bottles of their soft gel capsule products as they need based on their established dosage for the duration of the time that they're in the study for only $1 per bottle. And I can clarify that later. I know that's a lot of words. A lot of our participants do really appreciate the ability to contribute to research, as they hope that this work will help others in the future who are experiencing chronic pain. Inclusion criteria for this study, we are looking for people who experience chronic pain and have that listed as a qualifying condition on their certification for the New York State Medical Cannabis Program. So that has severe or chronic pain or neuropathic pain listed on their certification. We also have opioid analgesic use. So prescribed opioid analgesic use, as I described earlier, and medical cannabis certification. We need all of our participants to have an active medical cannabis certification in New York State in order to participate. So we also have created an innovative program for our providers. Recruitment is really, really challenging for research in general, and especially for research on the topic of medical cannabis for a variety of reasons. But one thing that we have always really relied on when it comes to recruitment strategies are the referrals of providers who are able to certify patients for medical cannabis in the state. So we've created the Provider Incentive Program. We can definitely talk more about that if you're individually interested, but if you are interested in participating, this is sort of the breakdown of how we compensate our providers for their referrals. And you can email Dr. Stephen Dahmer or Jasenia Lopez, the other clinical research coordinator on the study, for more information and to get enrolled in this incentive program. All right, and finally, how can your patients enroll in ReLeaf? We have a link to a REDCap survey, so an online survey. It's completely anonymous. It's a pre-screening survey. So if you give your patients this link, they can click it. It's about 5 questions. It's very, very quick. They fill it out. If they are preliminarily eligible, they will hear from one of our team members who will get them started with the remainder of the screening and enrollment process. This is my direct contact information. Feel free to reach out to me at my email or my phone number as provided here. More information on the ReLeaf study is available on clinical trials as well. I will pass it back to you, Stephen.
Great, and we're doing this a little bit backwards, but additional upcoming events we want everyone to be aware of as well. We'll have a February 23rd webinar. We're going to iron out some of the kinks on our technical difficulties, but very exciting webinar. Dr. Paloma Layfelt will be joined by Dr. Riley Kirk, Dr. Mileby Shields, and speaking about flower, certifying with confidence. And then we'll have a large free CME event in Minnesota, April 7th and 8th of 2022. Very excited about this event, some fantastic lecturers coming to that event, and we'll be sharing more about this in the future. Let me just pause here for a second. Deepika, I see you there. Are you able to speak?
Okay, I'm unmuted. I'm unmuted.
Oh, fantastic. Let me pull up the slide here, and I'm glad you could join us, Dr. Arnstein. You're the star of the show here. Let me pull up the slide deck. Can you hear me okay?
I've been here the whole time.
Yeah, no, I know. And I'm glad that we got through the technical difficulties and apologize for that. Let me pull up your slides here. Great, it's an absolute pleasure after technical difficulties, and again, apologize for that, to introduce Dr. Arnsten, who is the Chief of the Division of General and Internal Medicine at Albert Einstein College of Medicine in Montefiore. And Dr. Arnsten's accolades could not fit on a slide, and I say that with the utmost respect. Also, I truly believe Dr. Arnsten and the team, Dr. Slawek, Dr. Cunningham, have been at the forefront of naturalistic research specific to cannabis and chronic pain. And I do just want to say, besides both of those points, just what a tremendous honor and pleasure it's been to work together and to witness the incredible dedication and advocacy for their patients. Dr. Arnsten, with that, I'll pass it off to you.
Okay, it doesn't look like I have any video, so good thing you had a picture of me. So this is, I'm going to give you some sort of detailed description of the MEMO study, the medical marijuana and opioid study, and give you some preliminary findings from the study. So could I have the next slide? Okay, so this is an article that was published in 2020, and it describes the protocol for the MEMO study, the medical marijuana and opioid study. And this is a study that was written by a grant application that was written by my colleague, Chinaza Cunningham, with help of all of the people listed on the slide, Dr. Starl, Zhang, Backhuber, Solar, Levin, Minami, and Slawik, and myself. And it's a study that was funded by the National Institutes of Health for about $5 million for 5 years to look at the impact of medical cannabis on opioid use among adults with chronic pain. Next. So this is tiny, but it basically says that the study examines how long-term medical cannabis use affects opioid analgesic use, specifically by content, THC and CBD. We were focused also on how long-term medical cannabis use affects HIV outcomes, as we have a significant HIV prevalence in the Bronx where we work. And we are measuring cannabis and opioid use many times, which I'm going to go into in a moment. We will be examining within individual participants how their use of opioids changes from time 1 to time 2, as opposed to comparing one individual participant to another participant, so that each person is their own control. Next. Okay, so this is an outline of how the study looks. So the circles that are white inside with a border are what were conceptualized as in-person visits. And then the circles that are small, filled in, represent 6 surveys that occur in between in-person visits by telephone, a smartphone, or by internet. And so the white circles are enrollment and then visits every 3 months. So a visit at 0 months, 3 months, 6 months, 9 months, 12 months, 15 months, and 18 months. And then in between those in-person visits are additional data collection through cell phone or internet survey. So it's an 18-month study. Next. So the white dots on the very top, those are the in-person visits, enrollment 1, 2, 3, 4, 5, 6, 7. And these are the things that we collect at those visits. So initially, we contact your patients and ask them if they'd like to be in the study and fill out a lot of tracking forms and medical releases and give them a debit card, which is then filled periodically as these visits are completed. And then at the subsequent visits, 1, 2, 3, 4, 5, 6, and 7, we do something called an ACASI interview, which stands for Audio Computer Assisted Self-Interview. And we ask about the domains that are listed here, medical and other cannabis use, opioid analgesic use, alcohol use, many scales relating to pain, depression, anxiety, insomnia, and healthcare utilization. We do some functional assessments. We extract data from the PMP, collect urine and blood for some patients, and obtain medical and pharmacy records and reimburse participants. So this is a schema of the in-person visits and the data that are collected at each one. Next. And I'm just going to show you a little bit about the ACASI interview. Next. So this is a person who's doing the interview. She's looking at a computer screen and she's wearing headphones and she's hearing the questions read to her by the headphones while she's answering them on this small keypad. Next. And these are the domains that are asked about during those interviews. So each of these is a validated scale that has been used in many research studies with many populations. So we assess a number of things about pain. I'm going to talk to you a little bit about one of them, pain catastrophizing, in a few minutes. We measure all forms of healthcare use, including accidents and injuries. We do a number of screens that look for addiction severity in alcohol, in tobacco and nicotine, and in other substance use disorders. We evaluate for these mental health conditions, anxiety, depression, PTSD, ADHD, and insomnia, and we assess quality of life. Next. And then this highlights what happens during the web-based questionnaire. So those are the filled in circles. And there turn out to be 39 of them because there are between 5 and 6 between each of the in-person visits. And to fill out these surveys, participants receive automated links to a survey that was developed by a technology company in conjunction with our research team. And the surveys focus on pain, medical and illicit cannabis use, prescribed and illicit opiate analgesic use. Participants receive reimbursement per survey and an additional bonus if all the web surveys are completed between the in-person visits. Next. So this is a screenshot of what happens on the web-based or telephone-based surveys. So people are asked a question like this. Think about the past week and whether something happened that either improved or worsened your pain. Think about how that may have affected your pain and your use of opioids or marijuana. Remember, the responses you provide are confidential. What number best describes your pain? What number best describes how pain has interfered with your enjoyment of life and how pain has interfered with your general activity? Next. Please answer the following questions regarding the first medical marijuana product you used in last week. So the participants are asked to write down the product that they used, where they got it, and then some additional questions about cannabis that may have come not from a dispensary. Next. And then these are some of the questions about opiates or narcotics. So we use terminology, narcotic, marijuana, that we might not use if we were talking to people in our offices because we're trying to make sure that everybody understands the question. So these last 3 screens showed what people are receiving through the web-based survey and filling out every 2 weeks. And what you can see is that this gives us a tremendous number of data points and it asks people to recall what they've done over the previous 14 days as opposed to over a longer period of time than that. So we say, for example, in the past week, how many days did you take this? In the past week, how many doses did you take? And this gives us very granular information. Next. Okay, so who's in the study? These are the people in the study. They have to be older than 18, speak English or Spanish fluently, have to be a new certification for medical cannabis. So we wanted to get a cohort that was being newly certified for medical cannabis and hadn't been using medical cannabis that they had gotten somewhere else in the prior 6 months. We also wanted the cohort to be people with chronic pain. So as I think everyone here knows, the statute changed quite recently, but when we began this study and up until then, chronic pain was we didn't have the opportunity to write any condition that we wanted to certify somebody. And so we focused for this study on chronic pain or pain that degrades health and functional capability or a qualifying complication of severe or chronic pain. The study has completed enrollment prior to the statute being changed. And so all of those who we enrolled in the study met these criteria. And they also needed to be using prescribed or illicit opioids within the prior month. And then with respect to inclusion criteria, they have to be able to provide informed consent. They have to be able to come to all those visits that I just told you about. And they have to not have a unique or unusual pain syndrome like those listed there, a terminal illness or current or prior psychotic disorder. Next. And what I've highlighted in red are those inclusion and exclusion criteria, which are verified by medical records or PMP data or what do we call it now? It just changed from the medical marijuana data management system to, I guess, the medical cannabis data management system. Anyway, these things are verified through there. Okay, next slide. So how are we recruiting? Next. We began with a target of 250 participants. As I told you, we had a particular interest in patients with HIV infection. So we had a target enrollment for those. In September 2018, we began recruiting initially through providers at Montefiore, and I'm going to tell you a little bit towards the end of the talk about our medical cannabis program at Montefiore, and working very closely with Vireo, who have been extraordinary research partners throughout this entire endeavor. We mailed letters to potential participants who we identified in medical records using query terms, and we posted flyers in facilities and websites. So this was September 2018. Next. And the next thing that happened was the COVID pandemic. But despite that, next, we were able to complete enrollment of our 250 participants in December 2020. Now, as you can imagine, all of that in-person stuff that I talked about, the walk test and the CASI interview, much of that had to be changed on the fly very rapidly to allow virtual completion of the study visits. And our study team were extremely nimble and enthusiastic and got everything done. Next slide. So we've done some analysis of some of the data. We haven't analyzed all 250 yet. And so the numbers are going to be a little bit different on the different slides that I show you, and this is why. So this particular slide shows our results when we had analyzed the first 185 people who had come into the study. So if you look at the upper left-hand corner, you can see that we screened over 800 individuals, close to 600 were not eligible for a variety of reasons. They didn't use opioids in the last 30 days. Their cannabis certification was too long ago. They didn't have pain. They didn't want to be in a study. Those were the main things. We enrolled 220 at this time, and 35 did not come in for the baseline visit, which gave us 185. Now we have 250, but when this analysis was done, we had 185. So at that time, this is on the right, how the patients in the study look. So they're about 55% female, their mean age is 54 years old. Almost 90% of them have graduated from high school. They're 37% non-Hispanic white, 30% Black, and 26% Hispanic, 78% unemployed, 17% with HIV. We have a pretty significant number of tobacco smokers, 37%, about 30% use non-medical cannabis, and small numbers use cocaine or heroin, and about 5% hazardous alcohol use. People had pain all over, but mostly in the back or neck or a limb. People could have pain in more than one place, and some people had pain in other places. Next slide. Okay, these are some of the initial publications from the study, and I'm going to go over some of the results from some of these papers. And so next, the first one that we're going to talk about is this one, first-year trajectories of medical cannabis use among adults taking opioids for chronic pain. So why aren't I telling you the most exciting thing, which is, does medical cannabis reduce opioid use among patients with chronic pain? And I can't tell you that yet, although I hope I can come back and tell you in a few months, because we're still following the patients. So we've just completed enrollment and we're following them for another 18 months. And we're being very careful about cleaning and collecting and analyzing the data and making sure that we know what it says. So I'm going to tell you the things that we're sure of, And then I'll tell you the things that I'm going to tell you next time I see you. So this paper just looks at this group. At this point, it was 99. And so, you know, most of our patients in the study have public health insurance. We also looked at problem or cannabis use or cannabis dependence or abuse from a instrument called the MINI. And that was 8%. Problem alcohol use, 6%. Tobacco use, as I said, about 30%. The mean score on this PEG scale, pain and enjoyment of life and general activity, is high. So people have a lot of pain. And then the next bunch of items on the bottom half of this table are the mental health symptoms. And so between 30 and 45% of the study sample had something or more than one thing. And those things were moderate or severe anxiety, moderate or severe depression, scoring high on a screen for PTSD symptoms or ADHD symptoms or insomnia, or this syndrome called pain catastrophizing, which I'm going to explain to you soon. So the people that are coming to us for medical cannabis for pain, as you all know, are suffering in all kinds of ways. And so what happens? So this is, we're going to look at this for a little while. So these are data that were modeled. We looked at all the data, all those data that we collected from all those 2-week interviews and 1-month visits. What did the person tell us they were doing in the past 2 weeks? And we put it into a statistical model, which identified 3 distinct patterns of use. And in the top graph is overall medical cannabis use, and in the bottom graph is high THC medical cannabis use. And the graphs are kind of similar. So in each graph, the dark line on the top represents frequent use. The dotted line in the middle represents occasional use, and the bottom dashed line represents infrequent use. And so our participants essentially divided into these 3 groups, and this may be consistent with your clinical experience. There was a group of about a third or so that were infrequent users, and a group that was similar size that were frequent users, and then a group in the middle. So what is interesting about these graphs is that they're fairly stable. So people sort of establish their pattern and then they stay that way. And these are the 3 things that we identified. They're a little bit different if we focus on overall medical cannabis use versus high THC medical cannabis use. So fewer people were frequent users of high THC medical cannabis than overall medical cannabis, and more people were infrequent users of high THC medical cannabis than of overall medical cannabis. So we see those differences. But essentially, we identify these 3 distinct trajectories of use over the first year of being in the medical cannabis program. Next slide. So what are some other differences that we observed between these groups? There was less vaping among the infrequent users. So vaping was much more common among the frequent users, 81 to 92%, depending on whether it was or the high THC. Vaping was in between among the occasional users. And we also noticed there was more discontinuation after 30 weeks among the infrequent or occasional users. So people who used frequently tended to continue to use, and people who used occasionally or infrequently were more likely to stop using. What did we not see? We saw no differences by age, gender, pain burden, non-medical cannabis use, cannabis dependence, mental health symptoms other than PTSD or alcohol use. So we might have thought that people with pain would be using more frequently, but we didn't see that. And we might have thought that people with pain, more severe pain might be using, people with more severe pain might be using more frequently or might be using higher THC, and we didn't see that. What we did see was that people who were white, non-Hispanic white, were more likely to use frequently. And we noticed kind of a U-shaped curve with respect to employment, where people who were employed tended to use occasionally. So they weren't frequent and they weren't infrequent users. So what this, if we go to the next slide, what this suggests to us in these conclusions is that among these 3 distinct trajectories that we saw, the differences were evident at baseline and stable, but there were few differences with respect to clinical characteristics. Instead, we saw major differences between clusters with respect to race, ethnicity, and employment status, which suggests to us that structural factors limiting access to medical cannabis may drive utilization, even among adults certified for medical cannabis whom we're assisting in facilitating in all kinds of ways for them to obtain medical cannabis. So we're seeing more frequent use among people who are white and different patterns of use among people who are employed. Okay, next slide. All right, so the next thing is we're going to talk a little bit about this study in the upper left. And I do want to point out my colleague, Dr. Deepika Slawik, who I know is on the call because she's texting me. She first authored this paper. Next slide. And we can move on. This is about pain catastrophizing. So what is that? Okay, so pain catastrophizing is a set of negative emotions or cognitions in response to pain, actual or anticipated. And it's common, it occurs in 30% of patients and is highly intertwined with psychological distress like depression, anxiety. People feel desperate or fatalistic about their pain. It may never improve. It varies among individuals, even in response to the same painful stimuli. And what has been noted is that among individuals with chronic pain, those with pain catastrophizing have higher comorbid depression, anxiety, and suicidal ideation, and impairments in attention, emotional processing, and PTSD. And also, unfortunately, chronic pain patients with high pain catastrophizing have poor response to pharmacotherapy or physical therapy or traditional modalities for pain. They may not want to engage in physical activity for fear of subsequent pain exacerbation and worse mental health. So what does pain catastrophizing have to do with our study? Well, we noticed a very high degree of pain catastrophizing. About 40% of people that came in for evaluation for medical cannabis for chronic pain were experiencing pain catastrophizing. And so we wanted to understand a little bit about those patients and learn how we might be able to help them. Next slide. Okay, so how does pain catastrophizing look? So this is a complicated slide, but basically we looked at the first 185 patients in the cohort, and we looked at 5 domains, which are these colors here. So one domain is pain catastrophizing, that's black. One is anxiety, that's red. ADHD is green, PTSD is blue, and purple is depression. And what we apply a similar statistical analytic plan, which is called latent class analysis, and saw that these domains traveled together. So essentially there were these 4 different groups. When we took these 5 domains, they sort of separated out into 4 distinct groups. And the groups are in this graph. So all the way on the left is the group called low pain catastrophizing, low mental health symptoms. So these people didn't really, there were 90 of them, so about half. They didn't really have a lot of mental health symptoms or a lot of pain catastrophizing. The next group over from the left is low pain catastrophizing, but with ADHD. So this group is about 20, and these people were not really pain catastrophizers, but they had pain and they had ADHD. The next group and the next 2, so the one all the way on the right and one over, had high pain catastrophizing, and you see that in the arrow. And in one of those groups, the mental health symptom that was predominant was anxiety, which is in red, and some depression. But in the group all the way on the right, those people are really suffering. They have pain catastrophizing, they have anxiety, they have depression, they have ADHD, they have PTSD. Now, I'm saying that they don't really have those things. They have screening scales that suggested that they are likely to have those things. So let me just be clear about that. So, you all take care of patients, and you know that, your patients are different, and there's a group here that is hard to treat and probably needs a little bit of a different treatment plan. Next slide. So what is that? So is there a linear relationship? Like when we move from left to right, from low pain catastrophizing and low mental health symptoms to that group that's the most symptomatic, do all of the things that we would expect to get worse? So those things are pain, intensity and interference, disability, quality of life, and insomnia. And for the most part, they do. So what we're doing is we're identifying a group among the patients who come to us looking for medical cannabis for chronic pain, who have high pain catastrophizing, worse pain intensity, pain interference, worse disability, more insomnia, worse quality of life. And we don't know yet, I can't tell you yet how this group is responding to medical cannabis because we haven't been able to do that analysis, but we're very curious to see whether we can identify a phenotype or a group that is going to be responsive, and to a more holistic treatment plan. Next slide. Okay, the last thing that I want to highlight, next slide, is our medical cannabis program at Montefiore. So this is not about the MEMO study, although this program has supported the MEMO study. And this was published a couple of weeks ago to our great joy in the New England Journal of Medicine Catalyst. We were very thrilled that the New England Journal of Medicine felt that this was something that they wanted to publish. We thought it was terrific, but we weren't sure that they would. So there it is. And it's a description of this program, the first 5 years of the program. And I'm just going to tell you a couple of things about it, and then we'll be done. Next slide. So this is our first 5 years. On the left is an accumulative and month-by-month graph of the number of patients that we've certified. We put in place this medical cannabis program at our academic medical center after quite a number of meetings and discussion with people in all different parts of the institution. And at the time that we did this analysis, we had evaluated about 2,000 patients, approximately 2,000 patients. And what this table shows is just how those patients, the middle column is those that were referred to us, and the rightwardmost column is those that we ended up certifying. And then we've just compared that to the Bronx population. So, the median age in the Bronx is 34. The median age among patients that we see is about 55. We see more women. We see a little bit fewer Hispanics and live in the Bronx. We see a lot of people on Medicaid. And our clinic is enriched for people with HIV, 15%, sickle cell disease. We have a big sickle cell program in Montefiore, and also a number of people with opioid use disorder. So we're continuing to collect data from this program and to interview these patients and to understand what's been their experience with obtaining medical cannabis. We're continuing to collect data from the MEMO study. And as I said, we'll be able to answer the question of whether people who start medical cannabis are able to reduce their opioid use within a few months, I hope. And if we go on to the next slide, hopefully there's a next slide. Oh yeah, we've also been able to, there's 2 more slides. We've also been able to write guidelines for the New York State Department of Health for therapeutic use of medical cannabis in New York State. And this was also, this project was led by Dr. Deepika Slawik. And if we move on to the next slide, I just want to say that, these are all the people who really get everything done. I didn't have pictures of everybody, but I want to point out Shanaza Cunningham in the middle with her White Coats for Social Justice sign. And immediately to the left of her is Gio, who's the project director for the MEMO study. And a number of the clinicians and authors are here, Dr. Slawik and Ross and Dr. Starles and Broger and others. So I'm happy to take any questions if that's possible.
Great. And maybe quickly, thank you, Dr. Arnstein. Amazing work. And maybe before we jump into that, just one last plug here too for the ReLeaf study. Recruitment has proven to be a challenge. And I know there are a lot of providers on the call here. Many of you probably gotten emails or calls from me already. We could use your help. And again, there is an incentive for this program, both for patient and provider, and we need help to continue to do this, the high quality research that Dr. Arnstein and her team does. And then let's open it up for a couple questions here. I will jump into the first one that we have here, and it makes me chuckle a little bit because it's what are the challenges of performing cannabis research in the United States? And I'm chuckling because maybe similar to our call tonight, you have to be very flexible and very persistent. But Dr. Arnstein, would love to hear from you. What are some of the challenges that you've faced in terms of performing cannabis research in the United States?
Well, some of them you touched on, Stephen. The kinds of things that the NIH would like to fund pretty much need to have, harm and adversity and, danger, children as, sort of keywords. There's just not a lot of interest in the National Institute of Drug Abuse in research that may generate beneficial impact of substances that have traditionally been considered illicit. And, there's a long history to this. So, getting the funding in the first place requires a certain amount of finesse. And then doing the research, also has a whole bunch of other challenges to it that all have to do with legal regulation and institutional review board approval. So, you can't just like write a study and do it. It has to be approved by an institutional review board, which is registered with, actually it's part of the same agency that the NIH is part of. And those people review your study and tell you whether you can do it or not. And there are many of them. And if you work at a medical school, you have to have a good reason if you're not going to use your own medical school's institutional review board. And our institutional review boards have different degrees of conservatism. And, ours felt very timid about approving research that could in any way be construed as us facilitating a federal crime, which would be like facilitating people getting cannabis. So they were okay with approving us observing people who are purchasing medical cannabis, but not helping them to, so finding those, there's always a pressure point that can be applied, but sort of finding that pressure point and being able to, to apply pressure in the right way is really been the challenge.
Yeah, maybe even just to add one comment to that, even after all of those hoops that I was able to witness and the challenges to that, even practical things like New York State regulations require that the dose of THC and CBD be written on the cartridge, on the label when giving to a patient. So we did have great partners with the New York State Department of Health to work within those rules to then allow for, specifically with the ReLeaf trial, for blinding and even third-party testing of placebo, which were new things for the program and a little bit outside the usual lines of regulations, but they certainly made amends and allowed us to do that. Good. Another question here. How do these cannabis studies get funded in the current landscape, and who sponsors the studies? And Dr. Arnstein, I'll send that one your way again.
I mean, there are probably dozens, maybe even over 100 cannabis studies that are funded by the National Institutes of Health right now. And the kinds of studies that they fund, generally are looking for harms. So people can get funded to do a cannabis study and like invite people into a human lab and have them be exposed to cannabis. And I'll tell you where that comes from in a second. And then get into something like a driving simulator and see how many mistakes they make. And there's lots of studies like that being funded. And for those studies, the cannabis actually comes from the NIH. They grow their own with the University of Mississippi. And they send it to the researchers and it says it has this much THC and it has this much CBD, and that's how it works. And in order to get that, you have to go through a process of applications that takes about 2 or 3 years. So that's the way that a lot of studies happen. The other way that studies happen is that people are just observed doing what they do in their life and are enrolled into a cohort, as we're doing with the MEMO study. And, our hospital has started a medical cannabis program. We've certified them. They go to the dispensary, they get their cannabis. We ask them all these questions during all these visits. And that's how we do the research. So we're not in any way providing cannabis. We're not facilitating its provision directly. We're just observing patients. So that's the workaround or the strategy that we've found. There are also foundations that support cannabis research. So the MEMO study is funded by the NIH. The ReLeaf study is funded by a private foundation. So a private foundation can have more leeway in what they're willing to fund. And so the private foundation that's funding the ReLeaf study was willing to allow us to use money from the foundation to provide cannabis to study participants. But our medical school was not willing to allow us to do that. So we, by working closely with Vireo, we were able to figure out a way for Vireo to also obtain IRB approval from a different IRB and to do that part of the project while the Arnstein IRB only approved the observational parts of the project. So that may be more detailed than you want to know, but it just gives you a sense of, what kind of plotting it takes.
Great. I think we got time just for a couple more questions. There are a few good ones here. And I think this is a very pertinent one. How do you address health equity concerns in these studies or amongst your cannabis patients?
Yeah. So, that's, health equity is really our main driver for starting a medical cannabis program in the Bronx at Montefiore and for making it part of regular primary care. So the program that I showed you takes place right inside the regular primary care offices, and all of us are also primary care doctors. And so, we're reducing or trying to remove, any barriers to obtaining care as a medical cannabis patient by putting the service right where people get their regular primary care. Now, there are some people who don't want to come to the hospital at all, and we're not reaching those people. With respect to the main issue with health equity, however, which is the cost of medical cannabis, there's not much that we've been able to do other than provide the certification essentially for free. When patients go to the dispensary, they either have to pay, or if the dispensary is able to provide discounted products because of a research agreement, then we've been able to take advantage of that. That is good because people are able to try cannabis, but it's not sustainable because people can't stay in a research study forever. So, the question, how are we addressing it? I don't think we really are, but we're trying to.
And I'm adding on my own question to this, Dr. Arnsten. Any thoughts on potential insurance coverage? I know that's asking you to look in the crystal ball, but.
I think probably there are people here who know more about that than I do, or have more informed opinions. I don't see insurance changing until the federal law changes and until there's a different scheduling. And, we had hopes for the new administration, but it hasn't been their priority. Although, I don't know, there's a lot of stuff happening over the last couple of weeks, I think, with Chuck Schumer trying to sponsor some legislation in the Senate. So, I think that's what's going to have to happen, is that we're going to have a different scheduling system and a different, a different set of federal regulations. And we may be going in the wrong direction because I think that we're looking to make more things Schedule 1.
Absolutely. And then a question came in about placebo blinding and psychoactivity. Any thoughts on, the challenge of blinding with one, or even potentially more than one arm having potential psychoactivity?
Yeah, blinding is always, tricky. And placebo studies are very interesting. There's a whole literature about placebo studies in chronic pain, which shows that people in the placebo arms of chronic pain trials, of trials for pain medications, tend to, have less pain over time. It makes it hard to find a difference between an active drug and a placebo drug because the difference is narrower than one expects. So I think the placebo effect is a thing, and it probably operates differently in different people. And if we could figure out a way to measure it, that would help us.
Great, and maybe we'll finish up on this question. Put you on the spot a little bit, but clinical studies are well and good, but are real life patients seeing success and results with these cannabis products? Maybe high level, what are you seeing as a clinician on the front line with this?
Yeah, You know, I think my understanding of the literature when we went into building this program was that, and this is what I would tell patients, about half of patients will get some relief. So if there were two of you sitting in front of me, one of you might get some relief and one of you might not get any. And the amount of relief that you would get is probably not going to be full. It's going to be some relief. And so, that's kind of the way that we talk to people. But, what happens in reality, what has happened, what I've observed is that some people get a lot of benefit and some people really don't seem to get any. And I believe that a lot of this has to do with the fact that people are not able to get up to an adequate dose because they can't afford it. And so the people, in general, and I really wish I could hear the experience of everyone else who's on the call, but, people, I have some people that I take care of who are taking, 6 capsules a day or 8 capsules a day, and they're functioning and that's what's working for them. And, I think if we were able to really give people a sort of full titration of a product containing both THC and CBD, we would be able to see whether people really get relief. But I think that it's so confounded by accessibility and cost that it's hard for us to draw conclusions. What do you think, Stephen?
Yeah, I mean, I think that, for one, even today I saw patients and I see these N of 1 stories that blow my mind. Severe CRPS, 20 years plus, everything under the sun, every opioid possible, ketamine, IVIG, and brought in capsules and said, this is the only thing that gives me relief. And I've been hearing those stories for 7 years, and I think is in part what pushed. And I think we, especially with chronic pain, but many other areas as well, there is that concern for hype, right? And certainly a placebo effect. How do we start to hone in on right product, right dose, right patient? And I do truly believe there's a role. There was a question about, is terpenoid content focused specifically on pain relief? No, it wasn't for these. That's yet a second layer that might be a future research project. I think there's a lot to learn about cannabis to hone in on a little bit more personalized care, and we're far from that. But again, just applaud this work, that you guys are doing. And I do want to just go back to Olivia and Jess and Gio and the entire team and the tremendous work behind the scenes that goes into that. I am starting to wrap up here, but I'll maybe stop. Olivia, did we forget any questions? Anything else that we want to add here?
No, I think we covered it. There's just there was one question regarding using cannabis recreationally. If you have a patient who shares with you that they are using any form of cannabis, that is not going to disqualify them from participating in the ReLeaf study. So if they're purchasing cannabis from a non-dispensary source, yet fit the other inclusion criteria that we described in the presentation, please feel free to send us our way. Our team is very, very good at kind of parsing out who may or may not be eligible, and the more people that we get to interact with, the better.
Great. And Dr. Arnstein, I love it when people always do that to me and they say, is there anything that we didn't discuss that you would like to? But I would like to offer you that opportunity. Anything that we didn't talk about or any other thoughts?
No, I really wish that I had more results to show. And so, I hope that we'll have them in about 6 months, and, we'll be able to come back and say, these were the things that we found. Please refer patients to these studies and help contribute to finding the answers.
Absolutely. And do just want to respect everyone's time. Thank you all for joining us. I love these webinars, and I certainly hope there are more to come. And again, the MEMO trial is ongoing, and we all look forward to, I saw a comment in the chat, excited to see those next steps and what that data reveals. And then ReLeaf could use your help to, again, contribute to that data. Very exciting to, for the first time, look at a higher THC versus a 1-to-1 versus a higher CBD versus placebo. Even something as basic as that, a high CBD versus a high THC or versus a 1-to-1 is really unclear. So excited about these next steps. Want to thank everyone for joining. Certainly all reachable. And if you have patients that may qualify, please don't hesitate to refer them. This recording will be available. We certainly hope to have more in the future. And thanks again, Dr. Arnsten. Thank you, Olivia. Thanks everyone else for joining. Have a good night.